She is a managing director at Sai Sri Hospitals, Prothutur, and she completed her both graduation and post-graduation from our KMC, and she was a very bright student and sincere and intelligent student, and she has presented antenatal steroid prophylaxis and won first prize during her PG meet, Gandhi Medical College, and one more in Thrissur. Both of us went there. She excellently presented her paper, and she presented her work on universal versus selective screening at Hyderabad, and served as assistant professor at RIMS Kadapa from 2011 to 13. And since studying, she is serving the Prothutur people and people of Kadapa. Over to you, Archana.
Respected teachers and dear delegates, good morning. Thank you very much for the time and introduction. Respected teachers and dear delegates, good morning all of you. First of all, I thank Harvard Society for giving me this golden opportunity to speak in front of my teachers. So, for the next 15 minutes, I will be speaking about management of pregnancy with obesity. So, why should we discuss obesity in pregnancy? Obesity is a silent pandemic. As we all know, the prevalence of obesity has been increasing over the past few years. So obviously the percentage of obese pregnant women is also increasing. And obesity poses great risk to both maternal and fetal health. So how to make it safer? Planning things beforehand and being ready to tackle the complications can definitely improve the outcomes. This is the epidemiology. Our states fall in high prevalence category. We can notice that all our South Indian states are in high prevalence category. These are the results of National Family Health Survey 5. According to this survey, 1 out of every 4 persons is obese now. We can clearly notice the increase in incidence of obesity when compared to 4th survey. 5th survey, there is clear increase in incidence. And more alarming and worrisome is the increase in childhood obesity. So in future, we are going to see more and more obese pregnant women. This is how we classify obesity according to body mass index. 25 to 30 is classified as overweight, 25 to 30 is class 1, 35 to 40 is class 2, and more than 40 is class 3 or morbid obesity, and if it is more than 50, it is super morbid obesity. This is how we grade panels. First grade is where it covers pubic hair length, second grade is where it covers the external genitalia, 3 is up to upper thigh, 4 is up to mid thigh, and 5 is where the abdomen covers things. This is important for us to plan surgical incisions. So coming to management, pre-pregnancy period is the ideal time to intervene. So this is the best time to counsel the woman regarding her weight and her nutrition, and also regarding the risks of obesity during pregnancy and childbirth. And our counseling should be in non-judgmental language. And this is again one of the best time to recognize any other pre-existing comorbidities so that we can initiate the management even before conception itself. And again, nutritional deficiencies are also more common in women who underwent bariatric surgery for weight loss. And these deficiencies can be diagnosed and even we can initiate the treatment. Preconception folic acid supplementation also has to be started at this level itself. Even though pre-pregnancy period is the ideal time, many times we see the woman as pregnant. So as soon as we see a pregnant woman, her BMI must be measured and recorded, and her obesity must be classified. Her BMI has to be recorded once again in 3rd trimester. Again, we have to identify, evaluate and management of any other coexisting comorbidities. And here also counseling is very important. Here counseling must include her weight gain expectations, her nutritional needs, need for regular exercise, and the family must be counseled regarding risks of obesity to both maternal and fetal health. Her nutrition is best tackled by an experienced dietitian. As there is lack of consensus regarding ideal weight gain target, focus must be on healthy diet instead of prescribed targets. The woman must be encouraged to take regular meals with nutrient-dense foods with low glycemic index, like fruits, vegetables, low-fat dairy, and lean meats. And the woman must be told that she shouldn't skip meals. That is actually counterproductive. This is how the complete requirement goes, but this is best calculated by the dietitian according to the woman's needs. Here we can see the adverse effects of obesity on the pregnancy. Literally almost all complications are more common in these women, like gestational diabetes, preeclampsia, preterm birth, labor inductions, and failed inductions are also more common. More chances of landing in cesarean deliveries, shoulder dysplasias, postpartum hemorrhage, all sorts of infection, and large babies and stillbirths. This is the FASTER trial. Here we can clearly notice that the incidence of gestational diabetes, hypertension, preeclampsia, and higher order birth weight, all these things are more common in obese women, and the complication rate is also increasing according to the increasing body mass index. The risk of preeclampsia, it is very important. This appears to double with increasing 5 to 7 BMI. And obesity and hypertension, these two are common cofactors in peripartum heart failure also. Obesity poses the fetus also, poses risk to the fetus also, like miscarriages, recurrent pregnancy losses, fetal growth restriction, and more commonly macrosomia, anomalies, stillbirths, and perinatal deaths. And these children, they are often prone to long-term morbidity also, like obesity and metabolic syndromes. Even recent studies show that even autism is more common in kids of obese mothers. So when the pregnancy falls into such high category, she definitely needs a few special considerations. She must be screened for gestational diabetes mellitus at the booking visit itself, and again at 24 to 28 days. Daily 150 mg aspirin must be supplemented. It is not low dose aspirin, she must be given 150 mg. And size of the cuff is very important when we are measuring the blood pressure. They usually need larger cuffs, that is 15 into 33 cm size cuffs. And her mental health has to be taken care of. These obese women are more prone to mental health issues like depression, anxiety, eating disorders, and low self-esteem issues. So antenatal screening, it includes both biochemical screening and screening for structural anomalies. Again, maternal obesity is a limiting factor in screening for structural anomalies. So fetal surveillance needs regular serial ultrasound growth measurements to follow the fetal growth. Many a time we need ultrasound to assess the fetal position also, as palpation is technically difficult. So while planning labor and birth, we need multidisciplinary team, and the approach must be individualized approach. Early anticipation of the potential complications is vital in the management, and these cases are ideally managed in well-equipped setups. So when it comes to induction of labor, naturally obese women, they are more prone to land in induction of labor, as onset of spontaneous labor is approximately half. That means they are twice at the risk of landing in induction of labor, and they are also more likely to experience failed induction. The incidence of failed induction also increases proportionately with her increasing BMI. As there are no standard guidelines regarding the ideal time to induce, when we as clinicians are confident about her fetal growth, and when we are confident of lung maturity, and when we are anticipating macrosomia, the pros and cons of expectant management and induction must be discussed with the family, and the decision is taken accordingly. Labor induction at 37 to 39 weeks has shown to decrease the incidence of cesarean deliveries. So during childbirth also, fetal heartbeat monitoring can be challenging. She needs prophylactic antibiotic even for induction of labor, because many and these people they land in cesarean deliveries. Active management of third stage of labor is must, and shoulder dystocia, emergency ABCS, PPH, all these complications are more common. Early anesthesia consultation must be sought for, and these babies are more prone to land in NSUs. So when we plan cesarean delivery, and here goes a small mnemonic by obesity, oxygen and blood must be kept ready, equipment must be ready. This is right from the BP cuff, we need special trolleys, special OT tables, good anesthesia workstation. We need trained and experienced staff. Intubation difficulties are anticipated. These women, they all need trauma prophylaxis, and yes, this attitude is very important while handling high-risk cases. This is how CDC recommendation goes for antibiotic prophylaxis. Preoperatively, cefazolin shot must be given. Here the dosage is based on the weight of the woman. If she is more than 80 kilos, 2 grams is sufficient. If she weighs more than 120 kilograms, 3 gram dose is given. And this is followed post-operatively by oral cephalexin and metronidazole for 2 days. Never forget to examine the tissue under the panels. The viability of the tissues must be checked for. So preoperative planning is must when we place the incision. Here we have vertical incisions and transverse incisions. This is the vertical incision. Even though vertical incision provides direct access, it is associated with a few other complications like increased operative morbidity, prolonged post-operative period of pain and respiratory compromise, and wound complications are also higher as compared to transverse incisions. So naturally transverse incisions are preferable to vertical incisions. Transverse incisions, it can be again high transverse and low transverse incision. Supraumbilical transverse incision provides better approach to lower uterine segment. As you can see here, when the woman has panels, the umbilicus is dragged up. So the anatomy is a bit changed. So placing the incision above the umbilicus provides direct approach to the lower uterine segment. This is the traxi retractor. It can be used for lower grade panels. This is the surgery sleeve. It actually helps us by improving the surgical exposure. When it comes to closure, nectar sheath is better closed by continuous double loop mask closure, and the ideal suture material is synthetic non-absorbable and monofilament one like polypropylene. Non-absorbable sutures, they offer longer wound security. Up to 300 days they offer wound security. And monofilament sutures are associated with lower incidence of infections. And when it comes to subcutaneous tissue closure, closure is always recommended if the depth is more than 2 centimeters. Here the ideal suture would be synthetic absorbable suture like polyglactin. The suture can be placed either in running fashion or intermittent sutures also can be placed. That is surgeon's choice. And routine use of negative pressure wound therapy and subcutaneous drains is not recommended. There is lack of good quality evidence to support routine use of these two things. And when it comes to skin closure, intermittent sutures or skin staples or subcuticular stitches, and all these things do a good job. But it is again surgeon's choice. But intermittent sutures and skin staples, they offer the advantage of drainage if at all there is any post-operative condition. So post-operatively, the woman needs early ambulation and adequate pain relief. The antibiotic coverage has to be continued, and all these women need trauma prophylaxis. All the women are given mechanical trauma prophylaxis in the form of compression stockings, and if there is any other associated risk factor, pharmacological prophylaxis is also recommended. Enoxaparin in the dose of 0.6 mg per kg per day. It should be started 12 hours after surgery and it is continued up to 7 to 10 days. These women, they also need breastfeeding support as obesity is associated with low initiation and maintenance issues. The fetus, the newborn also finds it difficult to latch to the heavy dress. Abdominal binder can be recommended and regular dressings must be done. Initial dressing is changed after 24 to 36 hours. Thereafter regular dressings can be done once in 48 to 72 hours. And suture removal, it should be done on 10 post-operatively. It can be delayed if there is any other complication. The woman must be encouraged for postpartum weight loss. Infection is the most dreaded complication after any surgical intervention. So, how to reduce the incidence of wound infection? By giving antibiotic before placing skin incision and minimizing the tissue trauma and decreased operative time. So, these cases are to be done by experienced surgeons. And closing the subcutaneous space along with wound care, personal hygiene and nutritious diet can definitely improve the outcome. So, to conclude, as the prevalence of obesity continues to rise, obstetric providers should be aware of the multitude of the effects it can have on pregnancy. Anticipation, early identification and timely management of the complications can definitely improve outcomes. Thank you very much for giving me this precious opportunity.